My name is Gagan Maui and I'm a solicitor in the military team at Bolt, Bed & Kemp. This is the second session in our webinar series, SCI in the military community, which our military and spinal injury teams have arranged in collaboration with the Spinal Injuries Association. I'm joined by my colleague Victoria Oliver, who's head of the spinal injury team. For those of you who were able to join us last week, we discussed the rehabilitation process with two members of the SCI community who are veterans and work for the SIA. As we all know, sustaining a spinal cord injury is life-changing and can affect every aspect of a person's life. Where that injury has been sustained in the armed forces, the injured person not only has to come to terms with the injury itself and all that brings, but also the loss of a military career and transition into the civilian world, which can be very challenging and impact upon that person's mental health. We are therefore very grateful to be joined today by Professor John Morgan, who's a consultant psychiatrist and very experienced in treating adults who have sustained spinal cord injury, to talk about the mental health aspects of spinal cord injury from a military perspective. Please feel free to use the Q&A box on your screen to put any questions to Professor Morgan, although we will discuss those questions at the end of this session just to allow it to flow freely. Thank you. Professor Morgan, I'll hand over now.
Well, thank you very much for inviting me, and it's an honour to be here in such an important area. I've worked for many decades in helping rehabilitation of patients, including patients with military settings, recover from spinal cord injury. I have quite a lot of experience of military psychiatry, including unrelated to this, injuries such as non-freezing cold injury and current concerns over larium and the prescription of that and its impact. So I like to think I understand something of military culture, but of course it's a different thing to have actually lived the experience, and also perhaps to have lived the experience of the transition from military to civilian life, which I think is a real shocker for many people. I'll talk a little bit also about sort of the history of spinal cord injury and how our focus on it from an academic point of view has shifted over the years. Going back centuries, I'm going to be talking about sort of a papyrus that had a commentary on spinal cord injury. But essentially the psychological aspects of SCI have become more prominent as, thankfully, survival rates have improved. Survival rates have increased hugely in the last decade, but therefore there is more and more concern about the lasting psychological impact of having suffered such an injury. Much of the research has focused on military conflict, and there's now a growing literature looking at civilians, but the experiences, I think, of military versus civilian personnel are very different. There's a remarkably high proportion of patients who suffer psychiatric damage as a result of their injuries, and that in many cases this is continuing a decade or more afterwards. So this isn't something that necessarily spontaneously goes away. It's also important, however, not to pathologize what's going on mentally. A lot of people adapt really well and they brush themselves down and they get on with life. And it would be wrong to sort of put everyone in the box of needing to have therapy, needing to see a psychiatrist. But a significant minority suffer, and often suffer in silence. They don't express their emotions. They maybe have instead recourse to alcohol, or they may become irritable, argumentative, difficult to manage. And particularly early on, unidentified psychological responses can be a real barrier to the physical rehabilitation process. It isn't sort of one or t'other, it's the psychological affecting the physical. And if you have someone who is in rehabilitation, who essentially is giving up on life, then that can rob you of that precious window of opportunity to engage in physical treatments. So the psychological and the physical are very much entwined. And I don't know if there are any physiotherapists in today, but I do find that psychologically minded physiotherapists can be worth their weight in gold and can often be a good entree into what's going on in someone's mind in a way that perhaps sitting in a room with a therapist is a bit more daunting. So early detection of patients at high risk of depression and high risk of post-traumatic stress disorder is important for interventions and for rehabilitation. And it has therefore the potential, firstly, to improve the treatment response to physical rehabilitation, and secondly, also to prevent that mental illness becoming embedded. In a more colloquial way, I think sort of young men in particular who are depressed aren't going around saying, you know, I'm sad, please give me comfort. They're going around, you know, holding up two fingers to the world and saying F off. And that sort of irritability, that anger that comes across is actually a type of depression. So young men become angry and irritable when they're depressed, and that can subvert how treatment progresses. But it is very important to spot and to tackle. The two big disorders that tend to be addressed in research are of post-traumatic stress disorder and also major depression. PTSD is often the most identified condition, and I think military medical culture is in tune with PTSD as a condition. It can be a little reluctant to diagnose it, and you often see people who in the military medical records, they're said to have adjustment disorder, and then as soon as they see a civilian, it becomes PTSD. But on the other hand, there are sort of screening processes in place for the diagnosis of PTSD. But I think this focus on depression and PTSD then generates a neglect of other conditions, and recent research suggests that there's a lot more going on than just people becoming depressed and just developing trauma responses. And so you have to bear in mind these conditions, which are perhaps less common but also very relevant. Addictive behavior is very common, and alcohol abuse is in your face. You know when it's there. But misuse of medications being prescribed, that can also be common. And patients on sort of opiate analgesia, which is very necessary for pain management, that can then get out of hand and become difficult to break the cycle. But eating disorders are also much more common than people realize. They're certainly more common in men than previously doctors realized. And obviously, many people with spinal cord injury are women as well as men. But having a spinal cord injury is transforming in terms of body image. You lose autonomy over your body, and an eating disorder can be a way of controlling your body shape and body image, but also a means of controlling emotions. This then is even more amplified if you suffer problems, for example, with continence, because controlling the food and the fluid that you take in can be a maladaptive way of controlling your body, and can also cause eating disorders to spiral out of control. Whereas someone with depression will generally present that to the outside world, eating disorders tend to be concealed and not necessarily regarded as a disorder. So I would sort of just highlight eating disorders as a not uncommon and much neglected consequence of physical disability. Recent research has focused on agoraphobia as, again, being common. And understandably, people can be very reluctant to go out and about. They feel a certain stigma as the world looks at them and scrutinizes them. They can develop panic disorder or social phobias when they're talking to people, and they retreat into their shell and they don't leave their room. Obsessional compulsive disorder is also common, particularly in people with a predisposition, where you become very obsessive and rigid in the way that you're controlling the world around you. And much like eating disorders, it's a way of exerting sort of an inner control, given that the outer world is beyond your control. But then there are a range of conditions on the right-hand side of this slide, which relate to how the mind and the body interact. In my clinical practice, I sometimes see people whose paralysis is entirely psychological. and I provide input to a specialist unit which manages patients with these quite radically disabling conditions, which are entirely psychological. But the sort of area we're talking about here today, that isn't really relevant. But what is much more common is that someone with a physical injury, their interpretation of that injury is then magnified by their mental state. And then their mental state magnifies their physical symptoms. And it's a bit like a snake swallowing its tail. At a basic level, the way that you perceive pain is influenced strongly by your mood. So if I stood on your toe, a message would go from your toe to your brain to say, ouch. But what also happens are that messages go down from your brain to your spinal cord to affect the threshold at which you say ouch. And so parts of the brain, such as the thalamus, are controlling the perception of pain through experiences such as memory. Therefore, pain perception is influenced by your mood state. I'm sorry if that sounds a little sort of convoluted, my explanation, but what I'm at pains to say, sorry for the use of the word, is that I'm not saying that it's all in the mind. I'm saying that a very real physical experience of organic pain then becomes intensified by your mood, and then that exacerbates the pain in a vicious circle. And it's important that people understand that their pain is not being dismissed as all in their mind, but rather that psychological as well as physical factors contribute to pain experiences. At a more basic level, I used to provide input to a prosthetics unit in South London, and I well remember seeing two military patients who'd both sadly lost the use of their lower limbs through accidents. But one of them was sort of vigorously planning to run ultra marathons, and the other was living as if they were 80 years old, even though they were 20. And it really stuck in my mind that the same physical injury could produce very different responses understandably influenced by mood and by experience and by how they felt treated. So psychological factors influence the perception of pain, and psychological factors influence how you deal with a physical disability. I put a little link on my slide, a little hypertext link to a YouTube video of a much longer lecture I gave, lasting about an hour on psychological aspects of pain, just because I can't really do justice to it today. And I don't want to bore you all too much, but I do think that it's useful to understand how pain, emotion interrelate. So spinal cord injuries can be very distinct in military personnel, and the way that they are developed can also be very distinct compared to civilians. And I think the context of the injury can also influence how people are damaged psychologically. I find that that service personnel who've suffered injuries in the battlefield can cope remarkably well, because they have this sense that this was what they were trained for. It was, you know, a tragic but understandable experience. But sadly, I've seen a lot of military personnel with SCI, where their injuries have not been caused by that sort of experience, but often by, you know, sadly, someone else buggering up. And I think when you have a profound disabling injury because someone else has buggered up and not done their job properly, it's much harder then to accept what's happened to you. I think the corollary would be grief, that if you have a relative that dies of natural causes, that's much easier to deal with than a relative who's been knocked down by a car. In the same way, therefore, I think a spinal cord injury caused by tragic but understandable circumstances is very different in its psychological impact to one that really should never have happened. Spinal cord injury is particularly traumatic, but injuries generally are very common in military personnel, and almost 50% of all serving military personnel will have had one or more physical injuries in the last year. In the US, spinal cord injury in the military is 8 times the rate of a civilian population. And research priorities now are investigating the psychosocial issues relevant to people, as well as researching the impact on carers. And at the end of this talk, I'm going to say a little bit more about carers and how they might be affected. Rehabilitation is strongly affected by your mental state because there's a certain time span by which neural circuitry can adapt. So you can maximize your physical outcomes if you engage in physiotherapy vigorously within a certain time limit, and then it becomes too late. And if you simply retreat into your shell and develop a severe depressive illness, you're missing out on these precious times where physical treatment becomes all important. The history of spinal cord injury is of long and very historic. So a papyrus known as the Edwin Smith Papyrus from 3000 BC described spinal cord injury, and in those days described it as generally untreatable and often fatal. Hippocrates also described spinal cord injury, particularly focusing on bowel and bladder functioning. And then in World War I, I think a lot of medical advances happen in times of big wars, and World War I was obviously one of them. Most people with spinal cord injury were dying of urosepsis. So they hadn't yet learned the importance of managing the waterworks properly. By World War II, there was better knowledge of this and catheterization, which halved the rates of mortality. Something as simple as making sure people are properly cathetered and they're not going to develop what's called urosepsis was saving a lot of people's lives. And then as more and more people were surviving, renal failure became the big factor, and that with chronic recurrent urinary tract infections, people were starting to develop renal pathologies. And then that was improved by the introduction of better antibiotics. And so having rid ourselves of the 3000 BC outcome, which was generally sadly death, the World War I outcome, which was urosepsis, and then the World War II outcome, which was renal failure, we're now left with people who are surviving and sometimes thriving, but with the big issue now becoming much more the psychological, much more the social functioning, looking at ways of enriching quality of life, looking at social adjustment. Many people suffer what's called an adjustment reaction, which is a short-lived response lasting maybe days or weeks, and they dust themselves down and they get on with things. And if you throw psychiatrists at everyone, you can actually make things worse rather than better. In a separate incarnation, I wrote a policy for London about what should happen if there was a major terrorist attack. And I pointed out that it was important not to offer counselling to everyone, because most people cope with trauma by going down the pub, making a joke, chatting to their friends. And I think sometimes excessive psychology can undermine people's natural coping mechanisms. I think the comradeship and camaraderie that's experienced in military rehabilitation really is the biggest salvation psychologically. And I think, it's hard for someone like myself to understand what's going on emotionally. And it's you get much better support through peer support schemes. So I think we wouldn't want to offer psychiatric and psychological therapy to everyone, but a significant minority requires it and requires vigorous treatment in order to improve the early outcomes. It's important to manage people's expectations. There's been some really positive representations of disability recently in the media, but sometimes they give unrealistic expectations of, it's almost like overcoming your disability is a war in itself. It's a battle that you're going to win, and that sort of you're going to go from this, this disability to climbing Mount Kilimanjaro. And so people sort of engage in this battle, and then they realize that it's not like a Hollywood movie. And that can then bring a new wave of grief. So psychologists have been researching resilience, and they've been talking about concepts of what's called flexible goal adjustment versus tenacious goal pursuit, which is a lot of jargon, I appreciate. But what that means is that if you accept that this is your new life and this is what you can do, and you're going to make damn sure you're going to get the most out of the life that you've been given, then resilience is flexible. But if instead you convince yourself that you're going to conquer your disability and go back to how things were, the chances are that you'll be hitting your head against a brick wall, and you may therefore simply be delaying the psychiatric impact when you realize that actually things aren't going to go back to normal. So when we talk about resilience, it's important not to equate resilience with sort of this Hollywood movie representation of overcoming disability, that it requires a bit more subtlety and a bit more flexibility than that. What really helps psychologically is decent access early on to very good physical rehabilitation. So getting your physiotherapy, getting access to a good gym, a physiotherapist that has an awareness of psychological issues can be much better than a psychiatrist. I've seen a lot of people recently who've been extremely disheartened by the impact of COVID, experiences of physiotherapy delivered via telephone, I think sort of hands-on physical rehabilitation is one of the best sources of psychological support. But camaraderie can be crucial, and meeting someone who's had a similar journey to yourself, perhaps a year further down the line, can really inspire people. And therefore, a really good rehabilitation unit can work wonders in firstly creating this sense of camaraderie, and secondly, giving access to decent equipment. Unfortunately, however, I've seen a lot of military personnel who've not had access to those things, and they've had some pretty shoddy experiences, and they've been left frustrated because they've maybe felt they were left to rot on an NHS unit without much happening, and they've developed bed sores, and they've not seen physiotherapy, and they felt cut off and treated in a different way. The other problem is that in that decent effective inpatient rehabilitation unit, although it's really beneficial, it can also be a bit of a bubble. And then you get discharged and it's like a cliff edge. And in my clinical experience, it's often that point of discharge where the depression starts to hit home. People think they're fine, and then they go home and they're suddenly confronted with a world where they feel different to other people. They perhaps feel stigmatized because of their disability. They're no longer in touch with other patients with similar disabilities. And also the community-based resources simply aren't there. They've had a lot of inpatient physiotherapy, but there's no community physiotherapy. So effective early discharge planning is really important from a psychiatric point of view, without which people feel they've just been sort of shot out into limbo. Family and friends will respond in very different ways, and some people experience a huge amount of support, and other people feel that they've been abandoned. Of course, it's a two-way street, and sometimes when you've had an SCI, you don't want to be a burden to your family or friends, so you sort of shun them and you hold the world at arm's length, and then the world reciprocates. Particularly for military personnel, it can be distressing to keep up with some friends, and you hear about their adventures and their do's and their promotions, and you sort of think, well, I don't belong here anymore, and that can be really quite distressing. So it's important to manage people's reactions to those processes, and what I sort of think of as sort of a bubble effect of rehabilitation. Unsurprisingly, factors that predict the extent of psychiatric damage after a spinal cord injury would be the severity of the injury itself. And 28% of patients are meeting criteria for at least one major mental disorder after 3 years. So it's very common to experience some form of serious mental disorder. And that becomes particularly common where you mix a spinal cord injury with a traumatic brain injury, even a mild traumatic brain injury. And more than half of all patients suffering polytrauma will be experiencing sort of major depression or major anxiety, and they'll need sort of particular formal care for themselves. But predictors of these impacts also include the past. So, understandably, if someone already has a problem with depression, then that can predict a catastrophic outcome. If someone is already a heavy drinker or have addictive behavior, and perhaps in the past they managed it through their sports and keeping fit and going to the gym, and their rug is pulled from under their feet, and so the addictive behavior gets worse. Factors such as gender and age are also influential. Social structures can be influential. So, people's levels of support and whether they're in a relationship or not, and what happens to the relationship. The length of the hospital admission can make a difference, particularly the acute admission prior to rehabilitation. So these very prolonged acute admissions where perhaps you're not getting a feeling that you're being sort of pushed forwards, but that nothing much is happening. Also, the loss of feeling purposeful and useful, unemployment or being taking early retirement. And so the best way, I think, to look at the emotional impact of a spinal cord injury is to introspect and think about, what are the things that make my own life have value and purpose? And generally speaking, for me personally, it's two areas. The first is that I like to feel that I'm useful. And secondly, the ability to love and be loved. So if you're in a state of depression and trauma, and you're angry and you're drinking too much and you're telling the world to F off, and all your friends have left you and your partner is getting a bit fed up, and you no longer have a job and you don't know where you're going in life, it's pretty easy to understand why you might then develop quite a severe depression. The factors not, however, experienced as significant following spinal cord injury are changes in work and professional retraining. And so at a statistical level, where people have perhaps changed their job and their role, but they've carried on having a job and having a role, then that really is protective against severe mental illness. And that's where vocational rehabilitation and occupational therapy can be so important. Because if you feel that you've still got something to give and you still have a purpose and value in life, then that can work wonders. I'm aware of time, so I'm just going to keep going. the real factors that would say you probably need to get pretty urgent mental help would be if you were preoccupied with suicidal thoughts. By that, I mean that a lot of people after serious injury have feelings that their life isn't worth living, and they have days where they feel like giving up. But some people, they cannot get these dark thoughts out of their head, and they're plagued by them day after day. And that really, indicates that you should reach out for support and help. Another important area would be where you're sort of sabotaging things. You're almost deliberately sabotaging relationships. You're making a bad situation worse, and you're driving people away from you. And then alcohol and drugs are another sort of signifier of a really serious problem, as is managing anger and how you express your anger. I think anger is a really positive emotion. I've always felt that sort of anger is like isn't there a, anyway, I'm going to talk about my knowledge of rock songs, but anyway, I think anger is an energy, and it gives people motivation to get better and to show the bastards and prove that they're wrong. But anger that's either directed towards yourself or anger that simply sabotages treatments is clearly a very negative form of anger. So learning to channel your anger positively is important, not to get rid of your anger, but to acknowledge it and put it to good use. And then obviously giving up on treatment, just thinking, well, what's the point of this? I'm not getting any better at all. And sometimes the physical remedies are not dramatic, but they involve maybe sort of 3 or 4 little things all put together. But if you looked at any one of them, you may be thinking, well, I'm not getting anywhere. You might find that the last 2 months going to the gym with your physiotherapist hasn't really improved things radically. But actually, if you weren't doing that, things would be getting worse. And so it's easy to give up on treatment, but giving up altogether is a real sign of an emotional issue. The mild traumatic brain injury combined with spinal cord injury is this particularly toxic brew, and it doubles the rates of depression. It doubles the rates of PTSD and agoraphobia. And the brain damage itself can have a direct impact on how emotions are being managed. And I won't give you a neuroscience lecture, but parts of the brain can be affected in a fairly modest way, but sufficient to alter how someone regulates their feelings. So, if you've ever had sort of 4 glasses of wine, you can know that the way you deal with emotion becomes different. Well, for someone with a mild traumatic brain injury affecting the frontal areas of their brain, it's a bit like having a few glasses of wine. You're not sort of wildly drunk, you're not disinhibited, but it's having enough of an impact that it's affecting how you manage your emotions. And then you combine that with the spinal cord injury, and it makes a bad situation even worse. So in most cases, most people aren't going to have to see someone like myself. The psychological therapies, however, are really useful, and they would be typically delivered by a clinical psychologist or a therapist. Psychiatrists tend to be sort of held back until someone is perhaps needing management of a suicide risk, or there's a difficult diagnosis going on, or complicated decisions around medication. Whereas therapy to put feelings into words rather than behaviors can be really helpful. Psychology is often necessary, and therapies can address issues such as low self-esteem, poor body image, changing roles, way you're regulating your emotions, anger management. But psychology also has a crucial role, not for the individual patient, but for the broader multidisciplinary team. So where treatments are farmed out into the treatments of the body and the treatments separately of the mind, that's never as good as a good multidisciplinary team where the psychologist is part of the team, and maybe on a weekly basis, the psychologist is contributing to team discussions about a patient. It doesn't necessarily mean the patient is being seen by the psychologist, but the psychologist can formulate and inform how the physical treatments are being delivered. They can also help advise advocates and indeed solicitors on how to approach a case. Sorry, I'm pressing the wrong buttons here. So carers are a huge resource and are often much more use than therapists, but they have their own burden and they can get to breaking point as well. So I think psychology has a role also in meeting with carers and helping them understand the stress that they're under. It's far better to allow a carer and provide them with respite care and a bit of a safety valve than to get them to breaking point where they can't cope at all anymore and they themselves develop anxiety and depression. But in terms of you yourself as a person with a spinal cord injury, the most crucial thing is that there isn't a particular rule book. There's no sort of set of rules about you should be feeling this then. But it is a sort of process of grief. And there are stages of grief which are well characterized of, the initial shock and disbelief giving rise to despair and sadness. And then hopefully, eventually you come out the other end with a degree of acceptance. And so the psychological adjustment often mirrors those processes of grief based on feelings of loss. But people go backwards and forwards and they don't fall in boxes and they don't necessarily deal with things the way that they ought to. People will deny their condition and have unrealistic expectations. They think they'll be sort of, climbing Mount Kilimanjaro without any problems. And then they hit the reality and that can suddenly trigger depression and suicide. Or their anger can create self-harm, self-sabotage. You don't love yourself anymore, so you think no one else should love you. So you drive the people who do love you away from you. And your anger gets expressed towards your loved ones. And therapies can also help families, communication of feelings within families. It can be very upsetting to watch young children deal with disability in the family. And sometimes they'll make sort of heartbreaking statements like, I've come across, children saying, when are you going to walk again? When you're out of hospital, we'll be playing football again. And on the other hand, I think young children could be remarkably adaptable and resilient. In terms of your social network, you really learn who your friends are. And of the very many people I've been involved with, I think some have been surprised by how some friends have been absolutely brilliant and have really stood up for them. And other people have just felt completely let down and shocked by how someone they thought was their best mate hasn't really been bothered anymore. This particularly challenging experience of dealing with military friends where, they're coming to see you and they're perhaps talking about all the exciting things they're doing and the adventures they've had, and that can be quite heartbreaking. But also dealing with sort of doctors and nurses, they can be very supportive, but some of them aren't very good at all with emotions. Some of them can be very negative and can focus mainly on what you can't do rather than what you can do. So peer support is really helpful, and it can be sort of formalized through, formal community peer support and also peer-led therapy, which I think can be really helpful. And then at an informal level, you get the camaraderie of the unit, of the rehabilitation, but facing a cliff face after discharge. and simply having someone else to talk to about all the practical issues or discussing relationship issues. I'll gloss over this because I'm sort of somewhat overrunning time, but I think you know, therapy has huge value, but there's a vast variation in the quality of therapies and the quality of therapists. And you want someone, firstly, who's appropriately qualified, and secondly, you want someone that you click with. So you may find a very well-qualified therapist, but you just think, well, I can't get on with this person. They just make me feel miserable. So, you know, trust your instinct that if you see someone who's a well-qualified therapist, but it's not going to help you, then you can walk away from that and you can shop around until you see someone who actually is going to be helpful. So I've sort of slightly overrun by 4 minutes, but I think I've stuck to time, and I'm very grateful to you all for bearing with me and listening to me.
Thank you so much, Professor Morgan. That was incredibly insightful and informative. And I think you covered so many different issues that certainly within my experience of working with SCI clients, I recognise and I identify with so many things that we see along the way, as I'm sure that many people who've joined us today will do as well. What really struck me, and I'd be really grateful for your feedback on this, was your point about the sense of purpose and finding the end of the career not necessarily being a problem moving forward if you're then able to engage in something else and find a sense of purpose. Do you find that there's a distinction with civilian and military patients that you see, particularly because obviously with a military career, we're talking about, you know, then also transitioning into the civilian world and then trying to find a new sense of self and identity?
Yes, I think there are sort of two elements there. The first is that many military personnel are very invested in their athleticism. So they're used to being sort of fit and strong. And actually, I came across a fascinating description from the 1940s of a psychiatrist who'd looked at who had thrived and who hadn't thrived in prisoner of war camps. And your sort of your roughy-tufty PE instructor types often did quite badly, whereas your flabby intellectuals did quite well. And so I think sort of, you know, where you're used to running sort of, you know, 10 miles a day and suddenly that's taken from you, that investment in athleticism can make the loss of a physical role even harder, and adapting to a non-manual job or non-manual vocational role can be quite difficult. And then secondly, I outside of SCI, I see a lot of military personnel who become civilians, and you know, whether or not you've got a physical injury, it's bloody hard. I saw someone not long ago who just couldn't understand why in the business world, if you told a subordinate what to do, they didn't immediately kind of salute and obey you. You know, so I think the way civilian work is organized can be very frustrating to people in the military, because it just seems so inefficient. So you combine that, the inevitable challenge of military to civilian work with the loss of physical abilities and superimposed depression, and it's a really sort of toxic cocktail.
That's incredibly helpful, thank you. One of the questions that's come through, I'm just going to read it out if you'll bear with me, is do you think litigation can have a negative influence in respect of mental health, and can this affect recovery? If so, how would you suggest any negative influence might be mitigated or managed?
Well, I think defendants litigation can. So I think if they simply sort of put up their hands and said, yes, we'll do what you're asking, that would be great, wouldn't it? But it's when the battle goes on and is sometimes experienced as inappropriate, where there's an unnecessary prolongation, where perhaps experts instructed appear to be partial or self-serving. I mean, I won't breach confidentiality, but this morning I assessed someone who'd had a really positive experience of a defendant expert, and that was really helpful and reparative. But where you're getting these battles going on, I think for the individual, it can feel like you're a little pawn on a chessboard being pushed around. And certainly sort of litigation can overwhelm people. One way of managing it is to get support from a family member or friend, so that it's not you necessarily who's taking the emails direct, but it's going perhaps sort of via your partner. Another is to kind of put it in the box and then take out that box metaphorically once a week, so you get your emails, but you don't necessarily respond to them immediately. You give yourself a bit of a break and then you go back to them. But I think ultimately one would like to see the legal process being somewhat reformed, so that there was more sort of joint instruction and less sort of unnecessary conflict.
Thank you, that's really helpful. And I think in particular, just in general, being able to box things up and only deal with them rather than letting it take over is an incredibly useful tip. And I'm sure that applies across the board to people who struggle with overwhelm. Another question that's come through, Professor Morgan, is excuse me, where an SCI individual subsequently takes up a non-military post, but providing a civilian support role to the military, is there a risk that this may aggravate or heighten feelings of loss, inadequacy, etc.?
Very much so, because the pride and the status that you derive from your military role, then it's almost rubbing your nose in things, and that can really add to people's feelings of low self-esteem, obviously dependent on the civilian support role and how it's managed. But it also exposes you to people doing the thing that you used to do and wanted to do. And it can be very galling, yeah, so I totally agree.
And the final question that I've got at the moment, but also there's a couple more coming through, which is great. Another question we have is, how can you recover mentally from PTSD, where the treatment I think that you've received from either Veterans UK or the MOD or your clinicians has been negligent and there's been mistreatment there?
Well, I think to recover from PTSD, you have to feel that your therapist has your best interests at heart and doesn't have divided loyalties. Sometimes subjectively, that's not people's experience. They think that, what they're saying and what they're talking about could be used against them. They can't be as open as they would like to. And I've also, as I've already said, seen this sort of process of sort of military-related treatments downgrading the severity, and then you see a civilian team and it seems much more appropriate. So I do think that unless you think your therapist has your best interests at heart, then you're not going to be able to recover.
Thank you. And another one, I think it's our final one, unless anyone has any more to come in, please do feel free. Professor, I found your comments on falling off the cliff face very apt for the many of our clients who have difficulty going through the medical discharge process. Do you think the impact of this, combined with the challenges of finding support on the NHS thereafter, might make service personnel more vulnerable as a demographic? And do you think there is enough support for veterans suffering these life-changing injuries?
No, definitely not. I think sort of veterans are let down by a whole host of services, including the NHS. And although there are sort of processes and policies designed by politicians to address that in theory, I think in practice they can be quite self-serving and tokenistic. So I know as an NHS psychiatrist, there's a little box that I've got to tick on these lengthy electronic forms I fill out as to whether someone is a veteran or not. But as far as I'm aware, ticking that box makes bugger all difference to what happens thereafter. It's just a way of collating information. Politicians get a lot of kicks out of getting photographed next to military people, and they try to sort of steal the kudos of that association. But I think it's often inauthentic.
It's really interesting you say that, because I think I guess that's probably a topic for a whole different webinar. So perhaps I'll stop there. Unless anyone else has any other questions, I'd like to thank Professor Morgan, for joining us today. I think all of the information you've shared with us has been incredibly insightful, and we're very grateful. I think we're all on a constant learning exercise and take a great deal away from this today. In terms of our next seminar, just to let you all know that we will be having our third session on Wednesday, the 19th of October at 1 p.m, where we'll be discussing employment issues, followed by people who have suffered spinal cord injury and the medical discharge process thereafter. And we'll be speaking to Mr. Gary Craggs, who's an employment expert and has served in the Army, about that process, as well as a member of the SCI community about their own experience of the resettlement process. So please do join us. We will circulate links in advance of that. But thank you so much to everyone who's attended today. We're very grateful. Thank you.